Here are my disclosures. I think it's quite normal for a biosymposium. And here is the faculty. So you see, there are a lot of people coming from all over Europe. All peoples are specialized in endometriosis treatment. And I will introduce them while we go through the agenda, but you see, I think that's the important part. We will hear from all over Europe. So first of all, Professor Oskari Heikinheimo will speak about the relevance of real-world evidence in endometriosis treatment. Professor Heikinheimo is a professor at the Department of Obstetrics and Gynecology at the University of Helsinki, Finland. He has numerous publications in international peer-reviewed journals, is associated editor at the Journal of Human Reproduction Update and the British Medical Journal of Sexual and Reproductive Health, as well as many other different journals where he's a constant reviewer. He has also served as a member of the European Society of Human Reproduction and Embryology Guideline Development Group on Endometriosis. Then we will hear about VIPOS, what can we learn about patients with endometriosis today, by Sarah Imboden. Sarah Imboden is a consultant at the Department of Obstetrics and Gynecology at the Inselspital in Bern, and she's the head of the Endometriosis Center. She's a member of the Endometriosis and Gynecological Oncology Research Group in the department. Her areas of interest and expertise include laparoscopic and gynecological surgery, endometriosis, and gynecological oncology. Then we will look at the long-term medical treatment evidence and experience with Dynogest 2 mg by Michele Vignali, who is an associate professor in gynecology and obstetrics in the Department of Biomedical Sciences for Health, University of Milan, Italy. He is also the head at the gynecologic endoscopy unit at Macedonio Meloni Hospital in Milano. He graduated from the University of Milan with a degree in medicine and surgery and specialized in obstetrics and gynecology, following which he obtained a PhD in endoscopic techniques in gynecology at the University of Milano. He has worked in centers abroad dedicated to urogynecology and gynecologic endoscopy. My name is Michael Müller. I'm the head of the Department of Gynecology and Gynecological Oncology at the University of Bern. We are the first certified endometriosis center in Switzerland and have a long experience as well as the lab as clinically in endometriosis. Today's aim is actually to demonstrate the relevance of real-world evidence to address important clinical questions in endometriosis and discuss what has been learned to date. To share the rational methodology and baseline data generated in VIPOS, the Dynogest post-approval study, and the largest real-world study in endometriosis to date. Then to discuss the clinical evidence and real-world experience supporting Dynogest as the long-term medical treatment of choice for patients with endometriosis. First of all, I want to ask you to turn your phones on silent. We all know that you have the nicest ringtones, but on the other hand, you will need your cell phones, so keep it near you, but just on silent. And the idea is really to actively participate in the discussion. And for that, you will have the possibility to download the app at the Seud page, and so you then can ask different questions. This session has been designed to be interactive. I think that's a chance that we have all the experts I just mentioned. So please ask the question via the official SED Congress app, but we also have some microphones. So you have the both possibilities, either to ask your questions on a classical way or with the app. It's often easier to formulate a question. So we will also have some voting. So you also need the app to vote. The idea, as mentioned, is really to be interactive. So let's start with the first question, and we will see then how many people downloaded the app. What is the name of Michelangelo's statue in Florence? Angela, Matthew, or David? Okay, so you will always hear music while you have the time to vote. So 96% of the people think it's David, a couple think it's Angela, and nobody thinks it's Matthew. So I think that most of the people had the right answer. So yesterday we asked, should we ask the name of the new royal baby or Michelangelo's famous statue? So we decided to ask this one, and actually most of people had the right answer. So the idea is really that you participate and that you can vote. Use the time when you hear the music to do so. Another very important point is actually that we ask you to fill out the audience feedback evaluation form at the end of the session. For us, it's very important to know what you thought about the symposium to be better next time. I think it's always good to improve this kind of symposium. As mentioned, we will speak a lot about real-world evidence. Real-world evidence can provide an important source of information about both the benefits and harms of therapeutic interventions. It's often derived from heterogeneous, large, ideally unselected populations managed in routine clinical practice, and derived from systematically recorded high-quality data sources suitable for research. I think that's the first and most important point. Real-world evidence is becoming an increasingly relevant and credible study genre, which looks at the accumulation of routine medical care and experience, increased focus on populations and healthcare system-specific factors, and methodological improvements. I think that's the very important part between real-world and randomized studies where actually you have exact inclusion criteria. So randomized controlled trials are designed to measure efficacy but not effectiveness. Randomized controlled trials primarily measure efficacy of an intervention under controlled conditions. I think this is a very important point to realize because we have always strict exclusion and inclusion criteria when we perform randomized controlled trials. They're designed to reduce the bias. Real-world studies measure effectiveness by providing information on the benefit of an intervention under real-world conditions. So it's really daily work, what we have in our clinical practice. Real-world data evaluates what is happening in normal clinical practice and derived from aggregation and analysis of real-world data elements. I think that's a very important point. So it's really what we do every day. So the perception of real-world data versus clinical data has changed over time. In recent years, there are increased number of real-world studies published, and that's indicating the growing acceptance and appreciation of this kind of study. These types of studies have probably become better perceived due to a number of factors. Methodological improvement, more sophisticated choices of datasets, better statistical methods, development of guidelines. So during the last couple of years, we had this big improvement. Also, the evaluation of large computer health databases contributes to improved perception, uptake, and application of real-world data. And being able to analyze query databases in real time allows rapid responses, which is important in managing public health issues. So it's really kind of a combination between clinical practice, clinical work, a big database, and what we see every day. So real-world studies are becoming a much more credible study genre than before. So that we better understand everything about real-world evidence, it's my pleasure to introduce Oskari Hankin-Heimo for the first topic.
Okay, hello everyone. It's very nice to see such a full house. And before going ahead, I would certainly like to thank the organizers of this Congress and of this meeting for bringing us all to Florence. Seud has really become one of my favorite meetings. Very relevant scientific content, very relevant clinical context. And then certainly coming to Italy from the north of Europe, it's sort of like getting a quick start to summer. So thank you for organizing this. So within the next 15 minutes, I should be able to convince you sort of on the promises and possibilities, but also challenges and limitations of the real-world evidence as regards endometriosis treatment. I've been involved in such studies for quite a while, especially regarding family planning issues, but now increasingly going also into direction of endometriosis. And we'll get back to those towards the end of my talk. So the next slide just shows my disclosures. I'm working both for the Hospital and University of Helsinki and Finnish Medical Society, some consulting work and some board memberships. Finnish Medical Foundation is a major funder for biomedical research in Helsinki and vice president for the Finnish Society of Obstetrics and Gynecology. So enough to keep me occupied. So this shows the different study designs that there classically are. Certainly randomized clinical trials are very difficult to, expensive, difficult, time-consuming to perform, but of course also graded as sort of the most reliable, sort of the top-level evidence. And we see all different treatment guidelines or Cochrane reviews. RCT results always get very high status and very high priority. And then we have the other studies, real-world studies, observational studies, cohort studies, case control studies, cross-sectional studies, which can certainly also be prospective or retrospective. We'll be discussing those in a bit more detail in a minute, but just to highlight sort of the rarity of randomized controlled trials in the field of endometriosis or uterine disorders, I reviewed the Congress program this morning by using the app. I searched for the terms RCT or randomized or controlled, and nothing really showed up. Went through manually the program, and there were a couple of presentations sort of looking at the sort of later analysis of a previous randomized trial on endometrial ablation techniques, and then on the elagolix trial. So we have very limited RCTs in our field, so we have to live mostly with the real-world evidence in our daily practice. So this slide highlights some of the most common study designs in real-world evidence: cohort studies, case control studies, cross-sectional studies. Cohort study certainly follows a group of people, patients in our case, with a defined characteristic. Let's say women with endometriosis. They can be followed then, for example, using various databases. Do women with endometriosis have an increased or altered risk of cancer, for example? That would be a cohort study. You can also do the same study using the case control approach, where for each endometriosis case you then identify a relevant control woman and similarly follow them, let's say, with the use of National Cancer Registry or so. Cross-sectional study would be one, for example, looking at the diagnostic intervention. How does the availability of vaginal ultrasound affect the diagnosis of ovarian endometriosis, for example, just to highlight you some examples of the real-world study designs and approaches. And finally, of course, there is no holy grail in biomedical research. We have different study designs. Each one has its own strengths and weaknesses. Clinical trials, observational data, real-world evidence. We come to congresses and we hear presentations on these different study results. Occasionally RCT data, mostly real-world evidence data. And if this is sort of like a doctor's head, you pour all this in, include individual clinical expertise, then you shake a little bit, and then out comes hopefully improve patient outcomes. And sort of the truth is somewhere in the middle of these studies, and we all use these in our daily practice. It's time for the first vote. So get your cell phones out. How do you see the value of real-world evidence in your daily clinical practice? 1, yes, it reflects the conditions that I see routinely and the decisions I make routinely. 2, no, but I see how it could support my practice. Or 3, never, I only trust RCT data. If the study is not randomized, I stop reading it. So please vote. Very good. So I was already sort of able to convince many of you that the real-world evidence can be valuable in our daily practice. And we have 13% of diehards only trusting RCT data. Thank you for voting. Very, very good. So let's go forward. So this slide sort of highlights some of the things that we can pick up with the use of real-world data in our clinical work and in our clinical research. For example, we can pick up some long-term risks and benefits, say, of a treatment that one would never be able to follow in prospective trials, or infrequent events, let's say thrombosis associated with some hormonal treatments, or for example, treatment adherence. If we prescribe some medications to our patients, are we seeing the effect that we want to see? Maybe not. Are the patients actually buying the drugs that they have been prescribed? We might be able to use, if we have a national prescription registry, we can check if our patients have been purchasing the medications that they have been prescribed. Those are the kinds of things that can be studied through the use of real-world data and various databases. Certainly, each study is as good as the data is, and also all kinds of studies have their own limitations. Biases and confounders are important terms in real-world data. Bias, for example, the definition and selection of study population. For example, if we study women with surgically diagnosed endometriosis, and we'll see some examples of that, we are certainly going to pick the group of most symptomatic women, for example, and the women who have mild disease responding well to conventional hormonal therapies, those are then sort of automatically being left out. It's not right or wrong, but we just have to know this when we interpret the results. Certainly data collection is important. If we use various, let's say, hospital discharge registries, how careful the doctors are in documenting the correct diagnosis in the patient's charts. That becomes vitally important. And therefore, it's nice to see that we are going more and more towards structured patient files. Confounders. Is there something happening in the society which might alter the result? Let's say a new SRED treatment guideline or so, which all of a sudden changed the clinical practice, and all of a sudden we are seeing different results. So one needs to be aware of this. One needs to be careful in study design and analysis and in interpretation of the study results. Many of these can also be taken into consideration when choosing appropriate statistical methods when doing the analysis. These are some of the key areas in the field of endometriosis which can be and which have been and which are increasingly being studied using the real-world strategies. Effects of endometriosis on pregnancy and deliveries. There are higher risk of adverse delivery outcomes among women with, say, deep infiltrating endometriosis. What about trends in management and treatment? Have the patients, are they changing? Have they changed over time? Are there regional differences? Are those due to healthcare systems, or would there be through differences in the incidence of the disease? What about associated diseases? We are all aware of the certain cancers which are increased in women with endometriosis. What about other autoimmune diseases, associated diseases, or even mortality? Those things can be studied using the real-world strategy. We are all aware of the long diagnostic delay in endometriosis. This has been studied recently in an Israeli study, for example, in another Italian study. Differences in access to specialist care. Does the socioeconomic status of the patient affect the diagnostic delay? What about cultural influences? Is it okay for a young girl to have very painful menstruation, not responsive to oral contraceptives or painkillers? What do you do then? Or is there misdiagnosis? Are some of our patients being diagnosed as let's say, inflammatory bowel syndrome? So these are the kinds of things which emerge as cause of diagnostic delay. Another vote of the talk. What percentage of women below the age of 20 years report the onset of endometriosis symptoms? 1, 30%, 2, 60%, 3, 40%, 4, 10%. So please vote. 30. Okay, I already sort of forgot the options, but was number 1 30%? Was it so? Yes, yes, there they are. So number 2, 60%. I think 60 is the correct answer, but I think that the question might have been a little bit reformulated to, I think the appropriate question would have been what percentage of women below the age of 20 diagnosed with endometriosis report the symptoms before the age of 20. So 60 is the correct answer in this question. So let's go forward. This is a very nice study looking at the endometriosis symptoms, diagnosis, treatment pathways, associated socio-demographic things in 3 major countries, China, Russia, and France. And the lead author of the paper is Charles Chaperon. It was just published recently, 2016, and included about 1,000 patients with newly diagnosed endometriosis. And we see quite a bit of differences in regarding the different types of symptoms reported, patients with dysmenorrhea, patients with chronic non-cyclic pelvic pain, and then concerning the intensity of pain. And then when one reads these, you sort of wonder that are these differences real, or is it just the way that we are communicating? Are they cultural differences, or is there differences in the way we record things? Things to keep in mind when comparing different study results and different studies, and from different cultures and from different healthcare systems. That was the point with this slide. Now, some very recent studies looking at the incidence and prevalence of endometriosis. Actually, one from Finland. I'm very familiar with the study since I'm the senior author in it. Then there is another study, recent study from the north of Italy, very close to Florence, I'm sure. Another study from the state of Washington in US, Kaiser Permanente study. And a 4th study from Israel. Yes, from Israel, and this is from UK, looking at the incidence of endometriosis, looking at using different research strategies. The Finnish study, we required surgical verification of endometriosis. Then similarly as in the Italian study. In the Kaiser Permanente study, it was a diagnosis written in the patient's chart. So the diagnosis could have been made either clinically using ultrasound or surgery. And similarly in the Israeli study and in the UK study. So you see a little bit of different rates there. Some of the reasons for these differences might be also different diagnostic coding systems used. Most of the studies used ICD-9. The Finnish study used both ICD-9 and ICD-10, and already there are differences regarding the diagnostic codes for endometriosis between the 2 coding systems, and that causes a bias, something to keep in mind. Certainly, women with surgical diagnosis of endometriosis, they have undergone surgery, and they are most likely to represent rather symptomatic women, and not the ones who respond well to conventional medical therapies. 2 of these studies report a declining incidence of endometriosis or diagnosed endometriosis. Whether that's true or whether it's so that we are doing less surgical diagnosis, that's something that we can discuss, and we are maybe relying more on clinical diagnosis. Some of the summary points of the Finnish study, which was just published recently, and yet it involves a huge amount of work. We went through the Finnish hospital discharge registry and pulled out all women with the diagnosis of endometriosis, started with some 100,000 women, and then we checked whether they had a relevant relevant surgical code, only focused on the first diagnosis of endometriosis, and came up with a cohort of nearly 50,000 women, which were then observed over a period of 26 years. And that's a long time in the history of medicine, so many things have changed. As you can guess, certainly the use of laparoscopy increased quite a bit. The age at first surgery, certainly with the use of laparoscopy, has come down. That's good news. The rate of hysterectomy as the first surgical procedure has come significantly down as the age at which the hysterectomy is performed. So we are certainly relying more on ultrasound, on clinical diagnosis, starting treatment, using medical treatment, and if patient is well, then we are not doing so much surgical diagnosis. I'm very happy about this trial, and we can certainly are linking this cohort to various other databases at the moment. So these are just some of the questions that are waiting for their answers highlighted here. No reason to go through in detail, and I'm sure each one of us could think of several other things which we need to know and which would be important, especially for our patients and also for us as doctors treating the patients. And certainly these kinds of research strategies can be important, getting the answers and thereby helping us in future patient treatment. And this is the last slide. I thank you for your attention.
Thank you very much, Oskari, for this nice demonstration that real-world evidence is very important. So Sarah Imboden will speak about the VIPER study, which actually is the Dynogest post-approval safety study and the largest real-world study on endometriosis. Sarah, thank you.
Good day, ladies and gentlemen. The hard thing about lunch symposiums is you've all just eaten a sandwich and all your blood has drained into your stomach, and it's my job to get it back up into your brain because I have some interesting results to bring to you of this VIPER study, which is a typical example for real-world data. These are my disclosures. So what do we know and accept about endometriosis today? In 2014, in the publication of the Practice Committee of the American Society for Reproductive Medicine, the first conclusion was that endometriosis should be considered as a possibly chronic disease and warrants lifelong management. I think this is something which is nevertheless coming up more and more in the last couple of years, and if we accept endometriosis to be a chronic disease, we also see evidently that it's something which burdens women's health, that impacts their quality of life. And of course also when we're talking to healthcare systems, it's easier if we say, look, this is a chronic disease. It's evident that it uses healthcare and we need it. Everyone knows that we have good current treatment for endometriosis, but we all are confronted with patients which come back with recurrence, come back with long-term constraints, and we have to deal with that. And with the acceptance of endometriosis being a chronic disease, we know that it needs long-term management, and often we have complex cases. This is all not new, and we all have open questions, especially when we have the patient sitting in front of us, and they come and they say they feel better considering pain, they're under hormonal treatment, but they have effects on mood, they complain about the bleeding disorders, they may have problems with sexual life, or generally disturbance of quality of life. And when we want to know how long do the patients take the treatment that we prescribe, they don't all come back to us. So it's important when we see in real-world data what happens with the patients. When we're talking about long-term treatment, it's not only in studies which usually are 12 to 24, maximum 36 months. We want to be able to consult our patients in 5 to 10 years how they can take their treatments. So let me present you the VIPER study, the Visan Post-Approval Observational Study. It is a non-interventional, mandated post-authorization safety study constructed for Dynogest, but it's on all hormonal treatments for endometriosis. It's part of Bayer's commitment for post-authorization safety studies, which is very important, as we all know, and it is a real-world study. Of course, it is reviewed and approved by the EMA and has the quality seal of pharmacovigilance. It's the largest prospective study running at the moment on hormonal treatment of endometriosis, and we hope to have good insight of treatment of endometriosis today when this study is closed. Let's look at the study design. Again, the idea of the study is to assess the short and long-term safety of Dynogest and all other hormonal treatments for endometriosis in routine clinical practice, so not in a study setting in that sense. The patients come to the clinics which took patients for the VIPER study, and any patients with symptoms for endometriosis where the physician gives the diagnosis of endometriosis and is started on hormonal treatment, or the hormonal treatment is changed or restarted after 4 months can be included. We all know from the RCTs, we always have long lists of inclusion and exclusion criteria. And in these real-world data, the only inclusion criteria is that they're set on a hormonal treatment, have endometriosis or suspected endometriosis, and are willing to participate in a long-term follow-up. That's why the only exclusion criteria is they don't speak the language and can't be followed up, and everyone else can be included. Endpoint are occurrence of anemia, which requires treatment, and newly reported or worsened clinical relevant depression, which I think is an important side effect, discontinuation due to treatment failure. And if this happens, this is the patients which are telling us that the balance between the effect of the therapy that we're giving and the side effects of the therapy which we're giving, which unfortunately they almost always are, is not good, and that's when they stop taking the treatment. Most importantly, this study has until now, and it's closed for reputation, included 27,000 study participants. So this is a really, really large number which will give us nice information. VIPUS is similarly designed to all other post-authorization safety study, which, as we see in the presentation before, has evolved since the years 2000 and become really more well-formed. All self-reported events are validated. I'll get back to that in the next slide. There's an independent blinded adjudication for primary outcomes. And again, it's non-interventional. The patients come, they're set on hormonal treatment, and from there on we just watch and see what happens. It's very important that the self-reported events are real. That's why the institution which runs the study checks every single event which the patient gives, says to have in their questionnaire, and is classified as confirmed, as not confirmed. And if it's unclear, they call the patients, they call the physicians, so it's really clear that the event is true. Next to that, there's the second medical safety board, which monitors all the events independently. They don't know the outcome, but it's checked by doctors which are completely independent from the study. Very important for long-term studies is, of course, that there's a minimal loss to follow-up, which should stay under 5%, and is the case in the VIPUS study. For this, patients are contacted if they don't send back the questionnaires. They're reminded by letter, they're called, their uncles, their cousins, everyone they know, to really be sure that we have a very good follow-up. So let's look at the baseline characteristic of this patient. So again, these are 27,000 patients across Europe which have endometriosis. This is what we have, what we treat every day. They are 33 years old, they are 23.5 BMI index. This is the educational level, and it's quite surprising that almost 50% have a university degree. That probably also differs between the different countries. This slide shows how the diagnosis of endometriosis is given. The upper part here are the percentage that are diagnosed by surgical interventions. So basically you only get the diagnosis of endometriosis if the laparoscopy is performed. The lower part shows when it's diagnosed by clinical symptoms, and almost 90% are diagnosed this way. We see that between the different countries, however, a difference. Here, especially in Germany and Poland, it's up to 1/3 which get the diagnosis through surgery. We're back to voting. This is an interesting question. I look forward to your answer. What percentage of women do you think were diagnosed with endometriosis within the first year after occurrence of the first endometriosis symptom? 1, more than 70%, 2, less than 30%, or 3, less than 50%? So we have 12%, 70%, 70%, 30%, 20%, 50%. I also would have said it's less than 30%. However, if we see in the next slide, surprisingly, in this study, over 70% had the diagnosis within 1 year. This is very surprising when we know the literature. It probably has something to do with it. All the centers that were included, of course, are very sensitive to the diagnosis of endometriosis, and a lot faster if a patient comes to them to say, oh yes, you probably have endometriosis, compared to the mean gynecological praxis. We also see a difference between the countries. Also, where I come from in Switzerland, we seem to be slow at giving the diagnosis. Same in Germany and Poland, and it possibly has to do that up to now, usually the diagnosis endometriosis was more given after the laparoscopy was performed. Now we're going to look at the symptoms that these 27,000 patients have at the baseline questionnaire. So at that time when the indication for hormonal therapy was given, these are these pain symptoms. Between a score of 0, no pain, and 10, unbearable pain, 50% had moderate to severe pain. We know this. I found it nevertheless quite surprising that almost 10% come with unbearable pain, and this shows us the impact that patients have on their quality of life. If we turn it around and look at the typical endometriosis symptoms, pelvic pain, pain after doing sexual intercourse, and pain from menstrual bleeding, it's only 8.5% which show all these three symptoms. This shows the symptoms which were given by the patients associated with endometriosis. We'll go through the ones which are above 20% of the patients showing these symptoms. That's pelvic pain, pain during and after sexual intercourse, painful periods, heavy, probably more often irregular bleeding, and tiredness and weakness. I find especially the last point, tiredness and weakness, more than 20% say they have that as a symptoms of the endometriosis, which again shows us their impact on quality of life. This is for me the most important slide. This shows the treatment which was started at the time of the inclusion into the VIPOS study. And also this is a very good example for real-world data. We all know COCs are actually off-label use for endometriosis, but look, 60% of the patients were started on COC, most was in a long-term cycle. 11.7% was started on Dianogest, which is of course the primary point of the study, 9% GnRH analoga, other progestins, and actually quite surprisingly, still 3.2% were on danazol. That's a lot more often in the Eastern European countries where it's prescribed. Other hormonal treatments are NuvaRing, IUDs, and like that. 80% of the women included got their first hormonal treatment. I think this shows us that most of the patients, the 80%, are included into the study as a primary diagnosis. The rest are either switched from another hormonal treatment, that's 15%, or 5% which restarted after a stop of 4 weeks. So this collective is not our long-term chronic disease patients, it's really more included at first diagnosis. Of course, we're interested in the long-term use of Dianogest because it's the newest medication on the market. And these are the numbers from last year, September 2017. Over 600 women have longer than 15 months. And more importantly, almost 100 women have more than 4 years of treatment of Dianogest. And this will be very interesting to see these really long-term data when we get the results. So, VIPOS provides us data on real-world setting. We could discuss today a couple of patient baseline characteristics representing the symptoms of the patients which were included. It shows us the impact of the disease. I think a very interesting aspect is the regional differences that we can see. And again, it really shows us the impact on the clinical practice and not in the role of a complicated study. And with this, I think we see and can represent the journey the patients have with endometriosis. Thank you.
Thank you very much, Sarah, for these very interesting results. So let me just remind you that you cannot only vote, but you can also ask questions through the app.
Great.
So it's my great pleasure now to introduce Michele Vignali, who is going to discuss the clinical evidence and real-world experience supporting Dianogest as the long-term treatment of choice for patients with endometriosis. Michele?
Thank you, Michael. Good afternoon, everybody. First of all, I want to thank you to have given up a fantastic Italian meal outside and eaten this terrible box here in the audience, but maybe this can keep you awake. This is my disclosure. Sarah told us about the journey. We know that a patient affected by endometriosis has a hard and frustrating life, sometimes starting in the adolescence with painful periods and then cohabiting with chronic pelvic pain and then taking multiple medications and sometimes undergoing multiple surgeries. And the most frustrating thing is most of the time, these patients do not reach a definitive benefit for their disease. So it is evident to all of us that we must consider endometriosis a chronic disease that requires a lifelong management plan. And as we all know here in the audience, we can't cure endometriosis, we can heal this disease, but we can give care, we can take care of our patients. And so how can we do that? We can do that with maximizing the use of medical treatment in order to improve the quality of life of our patients. This is our goal, to improve the quality of life of our patients. So the question is, what is the best treatment, best medical treatment that we have in our hands? Actually, the ideal hormonal treatment should, first of all, ameliorate pain so that could improve the quality of life, less side effects. But together with the amelioration of pain, it's very important that this hormonal therapy is suitable for prolonged use, because this is a chronic disease, so we need a prolonged use medication. Guidelines recommend to use the hormonal therapy to reduce the endometriosis-associated pain, and we have seen and we know that hormonal contraceptives, COCs, and progestogens are able to control the pain due to endometriosis in almost 2/3 of the cases. But if we read these guidelines, if we read the ASHRA guidelines carefully, that was published at the beginning of 2014, we can read clinicians are recommended to use progestogens with a level of evidence A. In the same paper, we can read clinicians can consider prescribing hormonal contraceptive with a level of evidence B. So there is a little difference. And maybe this is the reason why Robert Casper last year published this very interesting paper that I really suggest you to read, in which he said, progestin-only pills may be a better first-line treatment for endometriosis than COCs. And why he said that? Because when we deliver COCs with estrogen and progesterone, we normally deliver the dose, even the lowest dose, 15 micrograms or 20 micrograms, we deliver estrogen that is 4 to 6 times the physiologic dose of estrogens that the patients need. And I remember you, but I know that you know it very well, that this is an estrogen-dependent disease. So we are creating a relatively hyperestrogenic environment that cannot help us to prevent the progression of the disease. On the contrary, the progestin-only pills can be used at any age, do not increase the risk of thrombosis, and it creates a relatively hypoestrogenic environment that could help us in suppressing and preventing the progression of the disease. What is Dynogest? Dynogest is a progestin. It's not a new progestin. It was synthesized in 1979 in Germany, and it received the approval for endometriosis in Europe in 2012 to 2013. It was commercialized. And what are the main properties of these progestins? To inhibit the synthesis of prostaglandins and to suppress the gene expression of aromatase. Aromatase is the enzyme that transforms androgens in estrogens. And together with all these other efforts that you can read here, essentially all these efforts contribute to the therapeutic effect of Dynogest, which is to reduce pain, to ameliorate pain, first of all, and then to fight the progression of the disease. And you can see this, and was one of the first paper published 2010 concerning 64 women with mild endometriosis, minimal mild endometriosis, that were put under Dynogest 2 milligrams, which is the dose that we use today, because this was a dose-finding paper. And they were put under 2 milligrams Dynogest after a laparoscopy, and 6 months after they do a second-look laparoscopy, and in more than 80% of patients, no minimal endometriosis was detected. Interesting. When comparing Dynogest with what was the gold standard, which is the GnRH analog, the leuprolide acetate, you can see 6 months of Dynogest compared to 6 months of leuprolide, you can see exactly the same effect on the pain, but obviously, as we know, the Dynogest offered advantages in safety and especially in tolerability, because we didn't have all these side effects that we have with GnRH analog. And these are the paramount of all the patients that have been enrolled in clinical studies with the use of Dynogest more than 1 year. You can see in the light blue, I don't see the color exactly, getting gold, you know. And the last 3 lines, the color is strange. The last 3 lines are the patients who are still under consideration for publication. So there is a lot of patients enrolled. And this is the first paper that was published in 2012-2013, which was the safety and efficacy study. It was a multi-center study published in Europe. The first part is a 3 months Dynogest against placebo, and you can see the different decrease of severity of pain. Then all the patients were switched to Dynogest, and you can see the progressive decrease of the severity of pain. And interesting, when interrupting the administration of the Dynogest, we still have 24 weeks of painful-free interval. The same results were observed in another kind of population, which is the Chinese population. This is a paper that was published this year. The time of the placebo against the Dynogest was longer, six months, and you can see they had the same results in terms of reduction of severity of pain. But one of the points of strength to me of the Dynogest is not only to cure dysmenorrhea. Dysmenorrhea it's the easiest pain to cure, because you put the patient in amenorrhea, and when you put a patient in amenorrhea, she won't have dysmenorrhea anymore. The other non-cyclic pain, dyspareunia, cyclic pelvic pain, defecation pain, all those pain that are related to the deep infiltrating endometriosis, the more difficult to fight. And as this paper is little cohort of patient, because it was 18, but was patient. It was about patients with intestinal lesions. And you can see that after 6 months, all the severity of pain was reduced significantly. And the same results in this paper published last year. It was a patient with intestinal nodule or rectovaginal nodule. And you know, when I say that, you know what I'm talking about. And you see that there is a dramatic results in the symptoms and a dramatic improvement in the quality of life. In both these papers, they didn't notice or encountered a significant reduction of the nodule. So you have a reduction of the pain, but not of the lesion. What about the side effects? You know that when we use Dynogest, one of the most frequent side effects is the irregular bleeding that you have in the first 3 months of use. And you see that this is a paper from a Korean paper that was published this year, a huge cohort of patients, 514 from 7 Korean hospitals. And you can see that the rate of amenorrhea increases with the passage of time, up to 90% at 18 months. And talking about long-term therapy, these are the data from Thomas Romer, about 36 months of therapy. And now I know that it's going to publish the 5 years results with the same patients. And you can see a tremendous reduction of the severity of pain at 12, at 24, at 36 months. And talking about safety, because safety is one of the parameters that keep the patient attached to the drug, because this is one of the essential parameters for the adherence to a therapy. And you can see the lipid profile and the liver profile was perfectly normal after 36 months. And sometimes I think this is a nice slide, because it comes from the paper of Lee, the Korean one that I told you before. And when talking about this discontinuation of medication, you see that the most frequent cause was the decision of the physician and not the decision of the patient, and this is very important. When we talk about endometriosis, especially long-term control of patients with endometriosis, we must face the problem of the recurrence. Endometriosis, unfortunately, is a recurrent disease. And as you can see, the rate of recurrence increases with passage of time. Either we are talking about ovarian endometriosis or deep endometriosis. And we know that when we are going to operate on an ovary with recurrent endometrioma, which was previously surgically treated for an ovarian endometrioma, our surgery will be at high risk of losing other ovarian tissue, and our surgery will be more harmful to the ovarian reserve and more harmful to the ovarian function than the previous one. So, get ready to vote. To what proportion of your surgical patients do you prescribe a post-surgical medical treatment? 1, 0 to 25, 2, 25, 50, 3, 50, 75, 4, 75, 100. 79%, 30%, more than 70. I wish better anyway, because I think that giving an hormonal therapy after surgery is mandatory. Mandatory. What's happening? Oh, yeah.
It's the wrong slide.
Oh.
Don't worry, it's the wrong slide.
Who did that? Miles. Correct. I'm glad with that.
Yes.
So you are right. Can we switch to the next one? Okay, so that's why, as I told you before, the guidelines recommend the use of hormonal therapy after surgery in at least for at least 18-24 months, and we know that from the study from Bercellini that when we give a regular COC after surgery for endometrioma, we can reduce the recurrence in 1 of 2 patients 3 years after surgery. And we even know from the study of Serracchioli that if you give in a continuous regimen, you can slow down a little bit, lower a little bit more the rate, which is anyway 8.2%. But what does Dynagest to the recurrency? Does it work? Yes, this is good news. Post-surgical Dynagest treatment is associated with a reduced rate of recurrence of ovarian endometrioma. These are 3 of the number study that we have. The first one, 80 patients who underwent excision of endometrioma, 40 were put under Dynagest 2 milligrams, 41 decided not to take any medication because they were wishing to conceive. And you can see this is the line of the Dynagest group, which is zero recurrence compared to 16.5 and 24% at 2 years. This is another study from Chandra published this year, 182 patients who underwent excision of endometriosis and put under Dynagest, and with a long follow-up of almost 3 years, you can see 1.5% the recurrence rate. And last, the one with the large cohort of patients from Korea, 514 patients with a long follow-up of 41 months, with an administration of 72, almost 1.5 years of Dynagest, you can see 1.8%. And when we put together all the papers reporting the recurrence rate of endometrioma after surgery and after Dynagest, because all these patients had surgery, were put under Dynagest, you can see with more than 1,100 patients, we had a recurrence rate of 2.1%. This is astonishing, with an 1861 months follow-up. And the last slide, because Michael is going to kill me, the last slide is very interesting effect of Dynagest on the size of endometrioma. For me, this is very promising effect, because you can see these are 75 patients who underwent surgery for endometrioma, and then they were put under Dynagest 2 milligrams, and you can see the progressive reduction of the size. The reduction of the size up to 30% of the initial size at 15 months. And this, for me, is a good weapon that we have, again, against the recurrence, because you can prevent the recurrence or you can treat the recurrence to prevent the surgery. So in conclusion, Dynagest, I hope that you are convinced about that, because I'm convinced about that. Dynagest 2 milligram is effective and tolerable as a long-term treatment, and long-term treatment is what we need, because endometriosis is a long-term disease. The patient tend to tolerate adverse effects due to substantial endometriosis-related pain relief, and is dramatic the reduction of the recurrence, because I was thinking about the reduction of the size. But for me, one of the most astonishing things that I've discovered looking at the literature is the prevention of the recurrence, which I believe is incredible. Thank you very much.
Thank you very much, Michele. Thank you very much to all presenters. So, as mentioned, you still have the possibility to ask questions through the app, and as we started a bit late, we will answer the couple of questions we have. And the first question actually would be maybe to you, Michele, and the others presenters. So for how long would you suggest to prescribe medical treatment?
May I say forever? I mean, this, as I tried to explain, is a long-term disease. So how long? I know that in the label there is written 15 months, but endometriosis pain doesn't last 15 months. So what I'm doing in my practice is to prescribe since the patient wishes to conceive, until the patient wish to conceive. That is what we do normally.
Sarah?
I think it's important to start them up on hormonal treatment after surgery, and then I think it depends how they tolerate the treatment. As long as they tolerate it well, I keep on going. If they want to get pregnant, of course, it's a different situation. And I think it's because treatment of endometriosis patient is a pathway, and so it can change at any time. But I think it's important that we get away from that we think we only have to treat them for 6 months and stop. If they tolerate it well, keep on going. If not, look for other solutions.
And Oskari?
I fully agree.
So at least we have an agreement on all speakers. So then I think there's a very important question to Michele again. Do you really suggest to treat rectovaginal endometriosis with Dynogest?
Symptomatic. Does it work? Do you hear me? Yes. I really suggest to treat vaginal endometriosis when symptomatic with Dynogest. I have fantastic results. Patient starting again to have an intercourses. So I remember to all of you that that endometriosis is not a cancer. Okay. So if they really don't have any problem with the obstruction or stuff like that, but you will see, because believe me, you will see, if you treat the patient with Dynogest, this patient won't have, I don't say at all, but they improve a lot their dyspareunia and they could return to a normal life. This is the experience.
So we heard about that all three speakers agreed that we have to treat patients on the long term until we then get kind of the side effects or they want to get pregnant. So the question now is, what would you recommend for treatment in adolescents? Dynogest or OCP?
Tough question. Personally, I would recommend COCs because there is at least to start with COC, because you know that adolescents have the problem of the bone development, and a progestin, even if it is minimal, you can have a reduction in BMD. So, and this is the same reason why we do not prescribe a 20 micrograms pill in an adolescent, but a 30 micrograms pill, because they need estrogen. So you can start with COCs. Maybe you can have the course of 4 months in continuous regimen, then you can have 1 menstruation, 4 months, just to see how it works, if the patient is good. And then after, you can pass to Dynogest. This is my opinion.
So I think that's exactly the point, is kind of, according to the data we have, everybody can have his own opinion, and we've already discussed a couple of times. To me, I don't have any difficulties to start with actually Dynogest, because then we stop after 6 months and it's reversible, what they saw on BMD, and there are no data on what is normal in adolescent, what BMD data are normal. So I think that's really according to your feeling. I try to do and to use what I think is best for the symptoms. So then another question that we already discussed a couple of times, but it seems to be a very important question. So I will ask the question to Oskar this time and not to you, Michele, because we already spoke about that. So how do you treat endometriotic cysts that are asymptomatic? Do you suggest to remove them, or do you treat them medically, or how would you treat endometriotic cysts which is asymptomatic? Okay,
so then obviously I would go to the ESRA guideline and look what's written in there. Asymptomatic endometric cyst, not associated with. I would leave it pretty much alone. Of course, then depending on the size and depending on the woman's age and so forth, I would take rather conservative conservative approach?
Yes, I think that it is a very important point. I think that everybody agrees that we should go or try to go through the guidelines, and the ESHRE guidelines kind of say that we should treat symptomatic endometrial cyst. I think we agree on that. I think the important part is really how they look at transvaginal sonography, and do they look suspicious or not. If they are asymptomatic and non-suspicious at transvaginal sonography, I agree with you that we should kind of leave them as they are. Are there any other questions in the... Yes.
Question to Professor Vignali. Michele, you showed the comparison between pill and Dienogest, okay? And some figure out different because the effect of pills is around 15%. You showed that the recurrence rate with Dienogest is much lower, 2 to 3%. So there is an explanation, and do you have any data with different progestins? I mean, noretesterone or something like that?
Well, thank you for the question, Ettore. I would say that maybe a hypoestrogenic environment could be better for our endometriosis. So as I showed you before, coming from the Casper paper, when you give only estrogen, while you give only progestins, you have a lower state of estrogens. So maybe this is better for the growth of the recurrence. And this is, we don't have a really comparison data. These are, I show you what it happens with the pill and what it happened with Dienogest, but I think nobody compare them, and I know that there is no comparison even for the pill. Just one paper from Cucinella, which is not a big paper, but we know from that progestogens has been used since I think 1990 for endometriosis or more, and the data that we have is not over a long time, because you know that the dose that we use for progestogens sometimes were too high, and so you had a lot of side effects, and so you have to quit the therapy. For what concerns NITA, normally it is used in Italy, for instance, at a very low dose, which is an off-label dose, because as the pill, as you say, because 2.5 is a quarter of the tablet, and NITA is approved for endometriosis at 5 to 10 milligrams, which gives a lot of side effects. But the rate of recurrence with NITA, I don't know.
Okay, so there are no comparison between COCs themselves. There are no comparison on progestins themselves. I just remember a paper from Giovanni Grandi that we published, I think, a year ago, where we looked at that in the lab, but no clinical data. So the last question, yes, you will be the last question for the dessert.
Okay. My question to Michele, could you explain the phenomenon? You have very good result to treat the pain during first year of Dienogest treatment, and the recurrence of pain after 1 year of treatment. Could you explain this phenomenon? You showed your
you didn't
figures.
Have. Why you say you have a recurrence of pain after 1 year?
Yeah, you show the good result after 1 year of treatment, but if you see second years of treatment, you have a lot of recurrence of pain during treatment of...
I didn't show that.
Now, I think you refer to the Korean paper where we where we see a slight increase, and I think that increase is due to the fact that the doctor stopped the medication.
But not the recurrence of pain.
No,
I mean.
that's because they stopped the medication. A percentage had again pain.
Not the pain. It was about the size of the endometrioma. You say the last one that I show you. You had a decrease in the size of endometrioma, then they stopped the treatment because it was more than somebody says, no, please, yes, like it happens. And then when they restart the treatment, the size of endometrioma went down again, but it was on the size, not on the pain.
Okay.
I did show a little one on the pain that was, no, I didn't show you that.
Thank you.
So I can't say.
Okay, thank you very much again to the audience, to all the speakers who had fantastic talks. May I ask you again to fill out the evaluation form? It's very important for us, and thank you very much for Bayer for organizing this exciting meeting.